This is about a 47-year-old gentleman having intermittent headache on and off for few months, much more and severe for a week. CT brain was done before and after IV contrast. Please go through the images and give the findings and the diagnosis. If you want more time, please pause the video and review again. Within few seconds, I'll give you the findings and discuss the differential diagnosis and the final diagnosis. Are you ready? Let's go. Plain CT shows ovoid hypertensive lesion in the lateral half of right temporal lobe. After IV contrast, this turned out to be a large vascular lake with mild perilesional edema around it. More prominent right sigmoid and transverse sinuses are also noted. In addition, multiple vascular collaterals are seen diffusely in the supratentorial and infratentorial brain, more pronounced in the right cerebral hemisphere. There is no evidence of mass effect or midline shift. No such vascular connections detected in the circle of Willis. MCAs and basilar artery are visualized. Thalami, basal ganglia and brainstem appear unremarkable. The differential diagnoses are 1. Multiple arteriovenous malformations. 2. Is cerebral vascular angiomatosis and rarely moya disease. Patient underwent MRI brain and DSA and the findings remain the same as already described. No therapeutic intervention done at that time. After discussing with the neurologist and the interventionist, we came to the conclusion of the final diagnosis of either cerebral proliferative angiopathy or cerebral vascular angiomatosis or diffuse AVM. In discussion, the associated syndromes with multiple AVMs or craniocerebral angiomas are 1. Sturge-Weber-Dimitri syndrome, 2. Hereditary hemorrhagic telangiectasia or Osler-Weber-Rendu syndrome, 3rd one is Weber-Mason syndrome, 4th von Hippel-Lindau disease, 5th is Klippel-Trinoni-Weber syndrome, 6th is angiomatosis of Divry-van Boge syndrome. When there are multiple arteriovenous connections due to multiple dominant arterial feeders and draining veins with or without well-defined nidus angiographically, then we can call it as diffuse AVM or cerebral vascular angiomatosis. But when there are multiple arteriovenous connections due to multiple non-dominant arterial feeders and draining veins associated with intermingled normal brain, then we can call it as cerebral proliferative angiopathy. There will be no typical nidus angiographically. See the image for the differences between the classical cerebral AVM and the cerebral proliferative angiopathy. Cerebral proliferative angiopathy is very rare, slightly more common in females. There is less incidence of intracranial hemorrhage at presentation. Might not have typical nidus but can have non-dominant feeders and have more collaterals from many parts of cerebral hemisphere with delayed transit time. The patient was managed conservatively for 1 year and then lost follow-up. That's end of the session. Thank you very much for your patient hearing. Please share this with your medical groups and with your neurological and radiological residents. Give your valuable comments, suggestions and feedback. Thank you again.